I really want to mirror the things that Dr. Westerman, Dr. Arcott said. I think when I hear their talks, it's like music to my ears. I think we trained in a very similar generation, and we have very similar views on how to take care of patients. I also want to mirror all the great things they said about patients' advocacy and your presence here. And one thing that I will add that I'd say a lot in my clinic is not just the patients with cancer, but the families of those patients. There are times where we have canceled major surgeries because patients didn't have the family support. And when I really look at my patients who have flown through big surgeries or done extremely well, a lot of that is owed to their family support to help get those patients up and moving. And so not only for the patients and survivors here, but for the families, thank y'all very much for your support, because this is a total team effort. I get to talk today on liquid biopsies in RCC. The title of this study, or this presentation, was actually how can we detect kidney cancer, and we'll go through some of the nuances of that. And I hope I portray or get across how excited I am about these. This is like the next frontier for us. I mean, this is so promising, and I would say an absolute gold mine for physicians, researchers, and patients. And so I really hope that comes across, and I will apologize for some of my examples that I use, but I want you to know how I think of these things. My current disclosures, I get research support from WHOOP, nothing that is specific to kidney cancer. So what is a liquid biopsy? I think we're very familiar what a biopsy is. It's a sampling of tissue. Usually that is from a surgical specimen, or a percutaneous biopsy for a kidney that would go in through your back. A liquid biopsy really is what it sounds like. We're taking some sort of fluid from the body and then trying to determine biopsy characteristics like a genomic profile or a tumor of origin. And so this is I would say this is the gold standard for a biopsy, and that's a surgical specimen. A whole kidney, as shown here on the right side, that has been taken out. You can see on the upper pole, or the upper half of this kidney, there's a gnarly tumor. And taking that kidney out is not only therapeutic, but it also provides our pathologists with the most information possible and allows us to do the most genomic profiling on that tumor. So surgical pathology in terms of biopsy is really our gold standard. We can also get biopsies percutaneously through the back, and typically this is done under imaging guidance, usually ultrasound or CT scan. And if you think about how big an apple is, when we take a biopsy of a tumor specimen, we're taking out a very small sample. So there is a item or an issue of sampling error, but we find that with contemporary techniques, biopsy accuracy has been increasing over the last 20 to 30 years. So a liquid biopsy, on the other hand, is non-invasive by definition. It's using fluid that is from somewhere in our body, and then we're able to determine the genomic profiling based on that sample. And so for various different types of tumors, there are different sources. So we can detect these in the urine and blood for kidney or bladder. For pulmonary tumors, they can get secretions from the lungs. And for GI tumors or colon cancer, we can actually get it from the stool. These liquid biopsies, what are we actually detecting? There's several variations on this menu, but the ones we'll really focus on are circulating tumor cells and cell-free nucleic acid, which I think is where the most promise is and where most of my excitement comes from. But I think we have to be really specific and careful with what question we're trying to ask. So the title of this presentation was Detecting Kidney Cancer. We're not necessarily there. We are not to the point where we are checking our blood samples of patients to determine if you have kidney cancer, okay? So it's used in a much more specific way. So what's the question we are asking? We are trying to risk stratify patients using these liquid biopsies. In other words, determine how advanced is the disease that we already know about. How high risk is that patient for recurrence or metastasis? It also allows us to identify patients who have had a complete response to therapy. That can be immunotherapy or systemic therapy or surgical therapy. We can also monitor patients while they're on therapy, identify patients that recur before a CT scan shows us, and to monitor the tumor while you're on therapy, meaning that how is that tumor changing while we're getting treatment, and can that show us a future direction of how we may need to change treatment. I use this example, and this is one of the first examples I will apologize for. I use this example in my clinic all the time. Cancer is like an anthill, okay? So when we do a CT scan and we see a tumor or a lymph node or metastatic disease, in my mind that is an anthill, right? The tumor cells are the ants. It takes millions or hundreds of thousands of ants to form an anthill, and so it takes millions or hundreds of thousands of cells to form a enlarged lymph node, a tumor, or a site of distant spread. And I think about my kids when they leave apple slices on the floor in the house and there's an ant, just because there's no anthill doesn't mean there aren't ants, okay? And I've never found an anthill in my home, but I see ants all the time thanks to my kids, okay? So this theme comes up a lot in how we manage patients and how we explain to patients. And kidney cancer aside, when we explain we're going to give bladder cancer patients chemotherapy before surgery, I tell them that the chemotherapy is taking care of the ants, the surgery is going to take care of the anthill, okay? So the most direct example of this is circulating tumor cells. These are actual renal cell carcinoma cells that are detected in the blood. And this is a study that had examined 195 patients who were receiving systemic therapy. And so again, this is whole tumor cells that are detected in the blood. Only 46% of those patients with metastatic RCC had a circulating tumor cell that was found. And then when we break down the patients that had 3 or more circulating tumor cells, those patients had a worse survival. And I think that makes sense, right? If you have more ants getting out of the anthill, that is likely to portend a poor prognosis. And this shows some of the survival of those patients. Now keep in mind, these are all patients with circulating tumor cells that were detected, so 0 to 2 versus 3 or more, and their progression-free survival, the amount of time that they lived without their cancer progressing or getting worse, was worse if they had more circulating tumor cells detected, okay? So circulating tumor cells. What I'm most excited about and what we'll cover about the most are cell-free nucleic acid studies. And it's important to know these are not necessarily all from the tumor. And you'll hear us talk mostly about circulating tumor DNA. Most of our cell-free nucleic acid in our bloodstream is actually derived from our own bodies, and it's from our white blood cells. And we'll see in a couple slides what the fraction that is derived from the actual tumor is. But in order for us to do a liquid biopsy, we also need to have some sort of germline testing or our blood tested to determine, for example, if I had a kidney cancer, what percentage of that DNA in Kyle's bloodstream is just Kyle, or how much of that is from Kyle's kidney cancer or kidney tumor. And this is the second example I'm going to go ahead and apologize for. And this is really how I feel or how I think about ctDNA and how this works, okay? So ctDNA is where we take a person who we know has a tumor of some sort, and we are trying to determine are there mutations peripherally in the bloodstream that we can detect that are not from the patient but from the tumor itself. And I think of this in terms of us trying to identify a song. That is the goal. There are multiple aspects in the anatomy of a song. There's a drum line, there's chords, there's melody, there's lyrics, okay? So if we assume that the primary tumor, like a kidney cancer, is an artist, we are given fragmented lyrics and we're trying to identify the song. So I plug this into ChatGPT, okay? This would be a tumor-naive approach. That means that we don't know what the primary tumor is. We don't know the profile of that tumor. All we know is there's a kidney mass, but there's no biopsy, okay? So if I plug this into ChatGPT and the fragmented lyrics we're given is that we know it's a country song, I lost my girlfriend, lost my truck, lost my job. That can be almost any country song, right? So it's not very specific, but it's very sensitive. It detects a lot of options, but it doesn't really help us to precisely nail down one song or one type of tumor, okay? What if we change again, I'm apologizing. What if we change the genre, okay? What if we say it's a hip hop song now and it's about butts and it's written to the opposite sex, okay? Again, we get a lot of options, less specific but very sensitive, okay? So this is a tumor naive approach where we don't know what the primary tumor is. What if we told you that the artist was Sir Mix-a-Lot? There's only one song that we all know that could be. So it really helps us to nail that down. It's too early to sing that song. Using a tumor-informed approach is much more specific and helps us to nail down the mutations that are detected in the blood that are derived from the primary tumor. Where this gets a little more tricky is what if we know what the primary tumor is and we identify those mutations. There's still variability depending on the question we're asking. And this is my example I give too, is that what if we knew that the primary artist is Red Hot Chili Peppers and the lyrics contain California? Well, I mean, that could be 12 songs, 5 albums, right? So it really depends on the question that we are asking. So I use this slide to illustrate that the importance of using a tumor-naive approach versus a tumor-specified or tumor-specific approach. So this is circulating tumor DNA. This is where we hold most of our promise, okay? If we do not know the mutational landscape or the genomic profile of that primary tumor, detection rates for ctDNA are very poor. All right, and it's only about 30 to 27%. So it's very important that moving forward, we use a tumor-informed approach or a bespoke assay specific to the primary tumor. This is a study that had analyzed patients with circulating tumor DNA, and I think what we'll see as a general theme for circulating tumor DNA across multiple cancer types is that patients with more advanced disease have higher tumor signal and we're more likely to detect circulating tumor DNA. And this has shown that patients with higher tumor burden, meaning more masses, more lymph nodes, more sites of metastatic disease, were more likely to have detectable ctDNA. So this is showing 8.8 versus 4.5 centimeters when we take the aggregate of all of their masses, lymph nodes, and tumors. Patients who are ctDNA positive had a larger volume of tumor. And what's most important there is that the patients with larger tumor burden that were ctDNA positive also had a larger number of genomic alterations identified. And that means that we know what the mutations are in that tumor, and that could help to direct therapy down the road. Not all circulating tumor DNA assays are necessarily on patients with metastatic disease. This is a study of 45 patients that had renal cell carcinoma completely excised. So patients at the end of the day after surgery, we think would be surgically cured. And again, back to the ants on an anthill example. We've taken out the ant hill. We don't think there's any ants left, but we're going to watch those patients. And they use a tumor-informed approach for ctDNA. ctDNA was detectable in 18 of those 36 patients, so half. And patients who were ctDNA positive had a higher tumor size and grade. And patients who were ctDNA positive after what we thought was a curative surgery had a poor relapse-free survival if that ctDNA was detected at any point. And there's a sensitivity of that of 84% with a positive predictive value of 90%. So in these patients, in that clinical scenario, we take out their tumor, but they're ctDNA positive at any point. That is 100% positive predictively for a tumor recurrence later. And not necessarily in the renal cell carcinoma data, but in bladder cancer, we've actually found that ctDNA detection after surgery will precede imaging findings by about 3 months. So imagine you get these scans done every 3 months after surgery, and we have a tumor marker now that's just from your bloodstream. And again, this example is in bladder. This hasn't been shown yet in RCC, but we could detect a recurrence of tumor before the CT scan. So that's, in my mind, very cool and can drive us putting patients on adjuvant therapy or salvage therapy quicker. This is an example really just to illustrate what we are finding in these studies or in these assays. We are finding multiple genes present in the primary tumor in the peripheral blood, and the reason this is important is some of these mutations are actionable. That means we have medications that can be directed at these tumors, so we have an idea of a susceptibility profile. Like if you get a urine culture, it grows a bacteria, we know what antibiotics work against it. This could be similar in the future as we develop new targeted drugs. This slide is just showing the patients who are ctDNA positive versus those who are ctDNA negative after their curative intent surgery, showing that the survival outcomes for patients who are ctDNA positive were poorer compared to those that were not. But what I would really illustrate here is that even in patients that were ctDNA negative, some of them can still have progression or a recurrence. So ctDNA is not necessarily perfect, but it's very promising and it's new, extremely exciting, and it has the ability for us to further the patient care in a very precise way. This study had actually analyzed patients based on their ctDNA profile compared to radiographic findings. And although this is a very exciting field, it really hasn't worked its way into standard of care or into national guidelines quite yet. Many of us use these studies in our practice, especially for patients with advanced tumors. But this is showing that patients who are ctDNA positive were more likely to have radiographic signs that correlated with that positivity. And so this study was able to correlate or discriminate patients that were going to have progressive disease partial response or complete response based on their ctDNA. And recall that I had mentioned the percentage of our ctDNA or cell-free DNA in our bodies being derived from the tumor versus derived from our own bodies. The difference in someone who is high burden versus low burden, when you consider the total amount of cell-free DNA, it's 0.3% is considered to be high versus 0.03%. So again, really critical that we have a patient's blood sample to know what is Kyle versus what is Kyle's tumor. And this is showing the difference in patients who had progressive disease while being monitored versus those that had a partial response or complete response, showing that they had a lower percentage of cell-free DNA derived from the primary tumor. Again, this is a study on metastatic RCC patients, in patients that had gone through treatment, and now we are using ctDNA as a profile to monitor patients and what changes are occurring in their detectable peripheral plasma. So 78% of patients in this 220 subject study had a detectable ctDNA, and this is in the metastatic setting. 64 of those patients had disparities in their genomic alterations after first-line therapy. That means that we have an idea of what they are before treatment or before systemic therapy. We treat them, and now we have a profile afterwards. And so we can see how the tumor is evolving and how the tumor is responding to that drug. And again, that gives us hope that we are selectively eliminating the tumor cells for which the systemic therapy is effective, and can also show us what the tumor will be susceptible to after that treatment. The largest differences in the study were actually seen in patients that got VEGF inhibitors. We still use these drugs, but this is one of the later, I would say one of the earlier studies. We're typically using now more immunotherapy, but still the concept being that we are seeing differences in the tumor and how the tumor reacts while on treatment. Again, using a circulating tumor DNA in metastatic patients, this was a pilot study analyzing 20 patients who had their kidneys removed. 45% of those patients were ctDNA positive, and they studied ctDNA levels before and after immune checkpoint blockade. And the reason why I included this study is that immune checkpoint blockade is really the mainstay of treatment now for RCC patients who have mets. And this really elegantly showed what this kinetic profile will look like, where we have ctDNA that is detectable, we put them on treatment, and that ctDNA decreases with time. That usually correlates with a good response. On the other hand, we have patients that have ctDNA that increases with time. That tells us that they are not responding to immune checkpoint accurately or the way that we would like, and that allows us to pivot and shift our therapy if needed. So, in conclusion, liquid biopsies hold tremendous promise in the diagnosis, prognosis, and response to therapy, and the recurrence of RCC. There are multiple modalities or assays used. I think ctDNA is the one we are the most excited about and has the most ongoing efforts in this space. There has been constant improvement in assay technology and detection over the last 5 to 7 years. I think what is most important to all the people in this room, myself included, and I should have included the slide from the FDA, but that multiple clinical trials are ongoing right now and are including these assays. And that is genuinely a gold mine to our knowledge and ability to understand these tumors. In that all ongoing trials, not all, but I would say most ongoing trials that are evaluating novel agents are using these assays so that we can better define patients that respond or patients that we need to shift treatment in.